A very, very good evening, ladies and gentlemen. Thank you so much for joining us once again. And this is, I believe, the grand finale of our Cancer and I series. And we've been running this in line with World Cancer Day on the 4th of February. And I think this brings kind of a nice curtain, brings down the curtain on this entire series, which has been spread out over these 2 months. We have worked with, I think, 10 different hospitals spread out all throughout the country. And we have had the wonderful opportunity to listen to insights from experts all across Malaysia in many different cancers. And this evening, for this last session, we are very proud and, of course, privileged to be joined together by our partner for this session, Subang Jaya Medical Center. And I'm especially pleased and extremely, honored to be able to welcome these 3 physicians who will join us in speaking from Subang Jaya Medical Center this evening. And again, I could think of no 3 other better individuals to kind of bring the curtain down on this session. Each of these gentlemen is a giant in his own right. So for me, forgive me if I do a fanboy thing over the rest of the evening. It's very like having each of the different Avengers on the show. So it's like Iron Man and the Hulk. I'm not going to name who's who. So it's just like Iron Man, Captain America, and the Hulk all together on one session. So each of them, as I was saying, is a giant in his own right in his own area of cancer management. And they've worked for decades in the field. And what is interesting is they continue to pioneer and lead a lot of advances in terms of treatment and management of cancer in Malaysia today. So we're very privileged this evening to be able to speak on precision medicine, cancer management of the future today. And we're closing with this session on this topic and speaking with these 3 particular experts, simply because as we kind of draw this entire series to a close, it's kind of nice to look and realize that, look, there's still so much out there. Every single day, there's a new clinical trial with a new set of findings. There's new drugs, new innovations, new therapeutics, new diagnostics. All of this, the best that we have in the field of medicine globally, is being brought to bear in the field of oncology. And what these gentlemen will tell you this evening, besides all these very interesting insights that they will share with you in these areas that they're speaking about, is also giving you really a message of hope. A message of hope in the sense that we may be just days or weeks or maybe even months away from discovering something which may break through in how we manage the disease that you have or a family member has today. So there's always hope, there's always innovation, and that's part of the discussion that we bring to you tonight. Our first speaker, ladies and gentlemen, is Dr. Matin Mellor Abdullah, and he's a consultant clinical oncologist at Subang Jaya Medical Center. Good evening, Dr. Matin. Thank you so much for joining us.
Good evening, Murli. There you are.
Such a pleasure having you on board this evening.
Thank you very much.
And and you're opening the batting for the SJMC home team today.
That's very true.
Right.
Yeah.
And you have worked in oncology now for more than 3 decades.
I came back in 1994, so it's been 3 decades now.
About 3 decades.
Oncology. Yeah.
Right. And really, like a very kind of general opening question to you. And how much has the field changed in the past 30 years?
It has changed tremendously, actually. And talking about precision medicine, I think that paint the picture very, very well. That fits into the the changing landscape of treatment. And in fact, what I'm going to show later on basically shapes some of the advances in oncology that has happened in the last 30 years or so. And it is encouraging, and where we're moving forwards is even more encouraging, with more advances and newer drug being discovered, new drug being developed and formulated, which is more targeted, more precision, with more precision.
Right. Lovely, doctor. And exactly, we're moving back into the realm. Ironically, I mean, medicine moved from treatment of individuals to treatment of populations. And now we're slowly swinging back to treating individuals once again, personalizing medicine even more. And ladies and gentlemen, precision medicine is something that Dr. Matin will speak to us about today. And just to put it kind of simply, no, I mean, nasi lemak is Malaysia's national food. I'm sure we all figured this out. But everyone has got their own individual nasi lemak shop or nasi lemak fix. And that taste is particular to you yourself. Even you and your sibling at home, or you and your wife, would maybe have a different taste in terms of nasi lemak. And no one can exactly fault that taste. You may like yours with sotong, somebody may like it without peanuts, some other person might like vegan nasi lemak. It's absolutely fine. And what is important is that we are starting to realize quite a bit that people are actually engineered the same way. Not everyone actually is individual, and they need to actually more and more look at being treated individually. And that's really the discussion on precision medicine. And I'm going to get Dr. Matin to kind of kick off the session, and he's going to speak to us this evening about being precise, about precision medicine and immunotherapy. Doctor, thank you so much. The stage is all yours.
Thank you very much, Molly. Let me just share my screen first. Okay, before I start, as being the first one from SGMC, I would like to just express our thanks then to NCSM for inviting Subang Jaya Medical Center to partner NCSM in this awareness session for the public in your Cancer and I series in conjunction with World Cancer Day with the theme of I Am, I Will. And you have alluded to the fact that our session today would focus on precision medicine. Precision medicine, cancer management of the future today. I'll be talking about being precise about precision medicine or precision oncology as it applies to oncology, and a little bit about immunotherapy, not a lot, but a little bit about that. So what exactly is precision medicine? So precision medicine, as with any of these definitions, we have to go back to the dictionary, and Wikipedia defines it as a medical model that proposes the customization of healthcare with medical decision treatment practices, product being tailored to a subgroup of patients instead of a one product, one drug fits all model. And crucial to the customization, diagnostic testing is often employed for selecting appropriate and optimal therapies based on the context of the patient's genetic content or other molecular or cellular analysis. And when you apply the same principle, same medical model to oncology, what we have is then precision oncology. And the goal of precision oncology is to deliver the right cancer treatment to the right patient at the right dose at the right time. And to do that, you have to identify the right patient for the right treatment, and that requires knowledge of the genetic alteration driving the cancer through molecular profiling of the cancer. And this is made possible basically because of the advancements, tremendous advancement in the profiling technologies like next generation sequencing. And I think, Dr. Muli, you've alluded to the fact that we talked about personalized medicine, and precision oncology has been used interchangeably with personalized oncology, when in actual fact, a patient's cancer, one patient's cancer, or the same cancer, for example, lung cancer, another person's lung cancer may not be the same. So the treatment is designed for your lung cancer. That's the term personalized oncology. But some people feel that personalized oncology refers to the fact that the cancer treatment is designed for your cancer, not anybody else, which is not really the case. It's designed for a group of patients who has got the same characteristics. Now, To understand a bit about precision medicine, we need to go back to basics and to just understand a little bit how cancer develops. And this at the very basic level, cancer develops due to alteration in a human gene. And this genetic alteration can be inherited or acquired. And inherited genetic alteration may lead to inherited cancers. And there are many examples of it. This is just some of the examples. For example, retinoblastoma gene, the associated genetic gene that's inherited is the RB1 gene that leads to retinoblastomas. Familial adenopolyposis due to the APC gene, breast and ovarian cancer, the famous breast cancer 1, breast cancer 2 gene that's inherited that give rise to breast and ovarian cancer at significant numbers of patients who carries that gene. Now, the majority of cancers are caused by acquired genetic alteration that occurs over time, and that's why most acquired cancers occurs in individuals who are generally older. Genetic cancers tend to occur in somebody who's younger in general. Now, alterations in these cancer cells can be identified by molecular profiling. I mean, this is putting it in a very simplistic term, not always the case, but the promise of precision medicine is based on the fact that the alterations in these cancer cells can be identified by molecular profiling. And if you can identify those alterations, then therapies can be designed to target that alteration, thus the term molecularly targeted therapy. And there are a few other names used. They're also called biological therapy, because the aim of the therapy is to interrupt a biological process. That's the term biologics therapy. And just to give people perspective and not think of molecularly targeted therapy as being the one and all, there are cytotoxic chemotherapy, and cytotoxic chemotherapy has evolved over the last 40, 50 years with some measure of success, but now I think most people do agree that it has sort of reached a glass ceiling already. Second big group is the hormonal therapy, and of course the third one, molecular targeted therapy, which we are going to be talking a little bit about. Just to complicate it a little bit more, molecularly targeted therapy can be broadly divided into two large groups, the small molecules and the monoclonal antibodies. And if I have to list the names of these small molecules and monoclonal antibodies, there are going to be hundreds of pages. You won't fill this page, you know. But suffice to say, they act at a cellular level to interrupt a biological process. Now, crucial to the advancement in precision medicine is the development of a biomarker. A biomarker is a measurable indicator of the presence of a disease or a cancer. And it can be used in different ways. And in precision oncology, a biomarker is useful to identify which patient benefit from which molecularly targeted therapy so that he or she can be given therapy which is most suited for him to work. And the advancements in molecular profiling has led to the identification of a number of molecular profile signatures that we can use as a biomarker to indicate what kind of treatment that the patient would benefit from. Now, this diagram depicts quite amply the fact that we are all the same, but actually different. So the top three individuals, the black, they could represent any cancers, for example, breast cancer or lung cancer or even colorectal cancers, any other cancers. So at the histopathological level, when you look at the specimen that's sent to the pathologist, the diagnosis will tell you it's a cancer. It's lung cancer or colorectal cancer or breast cancer. But when you apply the molecular and clinical profiling to the specimens that you obtain, what you might get are three distinct characteristics of the same cancer, meaning that instead of the cancer being black, it's green or blue or red. And of course, the therapies would also be different. So the therapy for the green cancer is a green treatment, the blue cancer with blue treatment, and the red cancer with red treatment. Now, I would try to demonstrate this with actual cases that we are in the clinic. Now, to demonstrate this, we know that non-small cell lung cancer has been the poster child of precision oncology, basically because a lot of the advancement in oncology was extrapolated by a lot of pathological advancement in the management, in the identification and the delineation of lung cancer. So lung cancer can be broadly divided into two large groups, i.e. the small cell lung cancer and the non-small cell lung cancer. The non-small cell lung cancer histopathologically are adenocarcinomas, squamous carcinomas, large cell carcinomas, and a mixture of any of these subtypes. And even when they actually look histopathologically different, they're all treated the same way. And up to the year 2000, the main treatment available then, the main treatment that was deemed to be the best was chemotherapy. And there are many different types of chemotherapy that have been tested. And this publication in 2002 on your right side basically shows, irrespective of what chemotherapy you gave, the outcome is the same. There's a median overall survival of something like 7 to 8 months with small cell lung cancer. So when I was training in Birmingham in the late 80s, early 90s, when we are faced with somebody with lung cancer, the consultant would say, when I ask the consultant, what shall we do with this one, sir? He would say, book the plot, meaning that, prepare for death. That was the statement then, but things have gone really, really advanced now. So again, looking at non-small cell lung cancer as the poster child of precision oncology, and in the subgroup of adenocarcinomas of the non-small cell lung cancers, advancement in profiling have indicated a lot of mutations that are termed driver mutation, meaning that these mutations are the one that actually drives the cancer to make it grow and divide and spread. And if one can devise treatment to target this particular driver mutation and treat it, you can prove that treating the driver mutation would give you a better result when you compare with the baseline standard of chemotherapy. So what we're seeing here is a pie chart that tells us the percentages of the mutation that are present. The most common one will see here is the EGFR, the epidermal growth factor receptors, the fusion ALK mutation, and the other mutation that you can see on your right side, the small numbers and your small percentage of non-small cell lung cancer. So we look at the example of the EGFR. So the premise is the non-small cell lung cancer that exhibit the presence of the EGFR mutation treated with an anti-EGFR treatment, so-called the group of drugs called the tyrosine kinase inhibitor. And when you look at the graph on the left side, the graph which is red color, which represent the anti-EGFR treatment, the patients who receive anti-EGFR treatment fares better in terms of their progression-free survival, as well as in terms of their percentage of survival at any one time. And this is not reported in only one study, but there are multiple studies that you can see on the table on your right side. In patients who display the presence of the ALK mutation on their cancers, the anti-ALK drug, when you compare them with chemotherapy, again fares better. Those who receive the anti-ALK in this situation, this crizotinib, the outcome as far as progression-free survival, as far as overall survival, is better in those who receive crizotinib as opposed to chemotherapy. Another example is the PD-L1. This is the only slides I have got with regards to immunotherapy. A certain percentage of patients with non-small cell lung cancer exhibit the PD-L1 positive status in the cancers. And if those who receive, in those patients who have a PD-L1 expressing tumors receive immunotherapy as opposed to chemotherapy, again, the outcome is much better, meaning that at any particular time frame, more patients who receive immunotherapy are alive at any time frame when you compare them with chemotherapy. And these are just 3 simple examples of this experience. And in fact, when you talk about all other cancers, the common other cancers, there are many other targets that one can actually identify, and they are treated with specific forms of treatment based on the mutation that they express on their cells. So to conclude, precision oncology is basically applicable to all cancer types, improving the outcome of treatment. And in the future, treatment of cancer may solely be determined by precision oncology if the offending driver mutation can be identified and appropriate molecular targeted therapy against driver mutation is available. And I think I must say if it's affordable. And this might require repeated biopsies, maybe liquid biopsy. And I think Dr. Pathmanathan may be talking a little bit about liquid biopsy to shed more light about what it actually means. And with that, ladies and gentlemen, Dr. Molly, thank you very much for giving me this opportunity to talk. Thank you.
Thank you so much, Dr. Matin. You're always very able to break down this complex information to really simple, deliverable pieces to everyone. Doctor, I wanted to check whether we could take a few questions.
Sure.
Okay, lovely. Doctor, there's one question on, and I think this is a bit lengthy, so I'm just going to kind of break this up. So the question is on repeated, actually, I think it's from your last slide, and this is on repeated biopsies. It says, I have known of patients doing a precision, or I think immunohistochemistry test, and subsequently first it was negative and then it was positive. Why does this happen?
Okay, so we do know that cancers do change their phenotype and the genotype in response to treatment. So, and that's the whole area where in oncology now there's a whole lot of discussion to decide when to biopsy. Should you biopsy? Whether you look at the profile of the specimen that was taken at diagnosis or as the disease progresses, because the cancer may actually change, that might be the right time to biopsy and profile them again. But doing all these things at this point in time, the inhibiting things are the cost associated with it. And of course, it's invasive, trying to do repeated biopsy to profile them. That's why my last slide actually shows that liquid biopsy. And I think Dr. Pathmanathan may be able to elaborate on that a little bit more later on. In essence, we would like to biopsy if it's biopsyable, if it's accessible and safely can be done. We would like to biopsy so that you can have a new profile. And if the tumor has changed, it will indicate to you why that tumor has become resistant to the drug that you were given before and what new treatment that you may be able to get. But I must stress, though, that sometimes, despite all those efforts, you might actually find the tumor still histopathologically and molecularly the same, that there's no new development, a new target that you can actually target and change the treatment,
Right. And I think, ladies and gentlemen, what Dr. Matin says is very relevant, because very often you get, actually, even for us, a lot of queries from patients on like, oh, why are they resending me for they did this test earlier and then they're resending me now, and then, the results have changed. And that's precisely why Dr. Matin is talking about how smart cancer is and how it mutates. And that's exactly the reason why, the oncologist or your treating physicians then have to look at new testing to kind of look at further addressing or managing that new recurrence or however it is of disease. Doctor, there's a second question on during my time. I don't think all these testing was available, and now I have recurrence of my breast cancer. Is there any way to retest or test again for my compatibility for new, I think, targeted therapies or immunotherapy?
Sure. Of course, you can rebiopsy that. It is almost always useful to do that. If the interval between your last treatment and you have been sort of in remission for many, many years, and you have got a new development of cancerous growth, number one, it would be useful to confirm that it is indeed breast cancer and not some other cancers. And secondly, you want to profile the cancer so that you know what is driving that, because in breast cancer, it's very useful to know the receptor status, the HER2 status, and whether it's triple negative, because the prognosis, treatment, all depends on that. Yep. So if there's an interval from which you were last free of the cancer, I think it's crucial that you do have the biopsy.
Right. Thank you, Doctor. I think that's a very, very kind of important point to make for a lot of people in those years who now, when these testing was not widely available. I think it's a good option to kind of look at rebiopsy if there's a lesion that reappears in recurrence. Doctor, there's one more question, and I think this is a kind of an economics question, perhaps, in
Economics.
that sense. Yeah, it's quite funny. What is this? So why do the doctors ask us to test for different tests, and then later add on different kind of, they're talking about immunohistochemistry tests. Can they not ask us to do all the immunohistochemistry tests at one go? Will it be more expensive? I suppose.
Okay, I think I can understand that question. Maybe Padma can partly answer that question later on because it's actually his fault in a way. So you see, when you when you send a biopsy, the first thing you want to know, the first question that patient want to know, is it cancer? Is it not cancer? So that's answered by the histopathological examination, HPE examination, and sometimes you also need to confirm whether the cancer actually comes from that particular organ where the biopsy was done, or is this cancer from somewhere else? And what helps with that is immunohistochemical test to confirm that it's coming from that particular organ and the other organ. So I think in terms of the testing, because of the cost differences, the histopathological test is done first, and then the immunohistochemistry is done a bit later, having decided whether the immunohistochemistry is needed or not. So in terms of the costing, so that's why the pathologist, the lab usually say, histopathological this much, but we almost always don't tell them about the immunohistochemistry until the pathologist then tell us, oh, we need to do immunohistochemistry. You need to go back to the patient and ask whether they want to get it done or not. But almost always patients say, no, if you don't do it, we won't know what it is. But they feel a little bit kick in the butt because you didn't tell them up front, that you do the HPE and then you do the IHC at the same time. But when you do it like that, the cost looks a bit more, expensive up front.
Yeah.
That's my understanding of the
And
situation.
oh, right. Lovely, Doctor. And there's a question on, this is quite specific. How do we understand what does a Ki-67 value mean when you test for this?
Ki-67 is just a value to indicate the differentiation. Again, the specifics of that Padma can probably answer it, leaving a lot of questions for Padma to answer. But basically, it just tells us whether the cancer is more aggressive versus less aggressive. But you don't use them by themselves because, you use them in a group together with the ER, PR, and the HER2 status. So there is a cutoff, and in some people's book, Ki-67 as a means of saying that cancer is aggressive versus non-aggressive, it's a bit of a gray area. And the cutoff point, which you say is positive or is negative, also is a little bit on a gray area. But people mostly believe 15% positivity means that the cancer is, or more, means that cancer is probably a little bit more aggressive.
Okay.
Yeah.
Doctor, and this is, I think, my question. And I was going to ask you to kind of explore to us, like now, a lot of the tests that we do sometimes, you get patients get back these results, and some of them, they tell you these are different markers, and we have no drugs for them to address these markers at this point in time. But
right.
Are there going to be drugs? Are they in the pipeline? Is this something where research is heading towards?
That's where research is heading towards. See, the one of the problems is when we do this NGS, and again, Padma could probably allude to that later on. When you do the NGS, you're basically doing, I think, a whole wide test, a blanket testing. So you're not looking for specific mutation in which the drug is available. So the promise was, we do this blanket test, we might find a mutation that's driving your cancer, and there might be a drug for that mutation in a different cancer that we can probably try to use in that sort of setting. But in practice, a lot of times you find mutation in which there are no drugs available. So one of the things that I always mention to patients when we talked about this molecular profiling is the fact that there is there's a big probability that having done the molecular profiling, that you may get a mutation that we don't have a drug for. And of course, this is where the general oncology is moving towards, because every mutation, they want to design a drug that may be efficacious for that. And there are a lot of mutations, and a lot of mutations, the significance of those mutations is not clearly defined yet. So to design a drug for a mutation which is of no consequence also wastes a lot of effort. So a lot of effort is actually doing a lot of research, looking at trying to really identify the mutation that are termed driver mutation, the main mutation that actually driving the cancer. So the main one that you want to address, and all the others mutation which are noise mutation that you don't really want to address them. But you know, these things are probably getting clearer by the minute, so to speak. Yeah.
Right. Absolutely, doctor. And just to kind of ask you as a kind of interesting side note, isn't it slightly more advantageous for people who have done NGS testing in terms of like access to newer clinical trials? Because I seem to notice that a lot of them have very specific new driver mutations that they're studying, and sometimes it's easier to enroll these patients as well.
That's true. The problem is that the problem with that is, number one, clinical trials are expensive. Clinical trials are not widely available, and clinical trials are labor intensive, and not many places are designed or able to carry out clinical trials in a very ethical and efficient manner. Yeah, so true that clinical trial is the only way to move forwards, but it's not practical to say somebody who's got a rare mutation in Malaysia, just send them off to, say, Australia or even Singapore to do the clinical trial, because it's quite intensive in terms of time and effort on the patients as well. It would be best if the trial can be done in Malaysia, but then again, you know, that's a different story altogether.
Right. That's right, doctor. And so what is this? I was going to close with this question, which somebody had asked. And in SGMC, when you kind of treat a patient, and is there like a consultation together with the pathologist, together with the radiologist? Is it something that is usually done? And I'm sure it is.
So that's the so-called the tumor board thing. I know in some hospitals they do that. Again, it's also time involved, it's labor intensive as well. Trying to get 3 or 4 doctors together can be quite difficult. But the individual level, we always discuss with the pathologist, radiologist when we do the scan. So we don't have an actual physical situation where all 4 or 5 will sit down together at one time. So what might happen is that the main treating doctor would have spoken to the pathologist, the radiologist, to come up with a proposal. Yeah? So that's called tumor board, which some places do have. Most places do not have that. So we have that for breast cancer, but with COVID, things have quietened down a lot of activities that involve face-to-face meetings.
Correct, doctor. But I think what you all are doing, like a tumor board, is a WhatsApp group as well, right? Because that's exactly
that's
what
right.
we needed discussion here.
Yeah.
Doctor, thank you so much for having us and joining us this evening. And as we close your segment, could I kindly ask that you leave us with a couple of takeaways in terms of precision medicine and maybe some good words to our audience?
Okay. So as far as precision medicine is concerned, it is the way forward. I mean, they aren't any further change from where we're moving now. We're moving forwards with precision medicine, with cancer treatment, which is very focused to the mutation that patients are actually having. So personalized medicine in a way. And we know that when you get treatment that's designed for your type of cancer, your outcome is going to be much, much better. So as I said, the future is bright as far as oncology is concerned. In the past, when I was treating lung cancer, we never see anybody surviving 1 year, but now we have seen people surviving 10 years even with stage 4 lung cancer. So I think we should never lose hope. We can always look forwards, and life is nothing without a fight.
Right. Thank you so much, Doctor, and for your wonderful sharing, and hope our members of the audience have kind of gained quite a bit, as much as I have this evening. Always a pleasure to have you on and to have you speak as well. Ladies and gentlemen, that was Dr. Matin Mellor Abdullah, Consultant Clinical Oncologist at Subang Jaya Medical Center, our first speaker for the segment this evening.
Thank you very much for having me.
Pleasure, Doctor. Our second speaker this evening, ladies and gentlemen, is, like I was saying, another giant in his field. And as I have mentioned in I think, previous sessions, very scary for me because he was my teacher as well. So please allow me to kind of welcome Professor Dr. Pathmanathan Rajadure, who's a consultant pathologist at Subang Jaya Medical Center. Good evening, Prof.
Hello, hi. Thank you for, I'm sorry if I was so intimidating as a teacher. But,
no, not at all, Prof. Just scared to ask you the questions now.
Yeah. So, thank you again for inviting me to speak and for inviting the audience. Sorry, give me a minute.
No problem, Prof.
I seem to have yeah, there we go. Sorry about that. I think this.
No problem, Prof. Okay, we've got the slides. Yep.
Yeah, I want to thank again everyone for allowing us, our team in Subang Jaya Medical Center, to speak to you and to participate in this educational session. I'm a pathologist by training, and Martin and Dr. Elente, as well as several of the other consultants and oncologists are my colleagues. And we actually share a commonality because we work under a similar environment. And there is quite a lot of communication and rapport as far as patient management is concerned. I've titled my topic Advances in Cancer Treatment, Finding the Magic Bullet. The magic bullet being the actual precision medicine or the drug. So Dr. Martin has already to some extent spoken to you, and I will keep my talk very simple, and I can take perhaps much more detailed questions during question time. I want to start also by talking to you about what happens in the normal cell. And if you go back to our high school biochemistry or biology, then this diagram on the left is referred to as the central dogma, where our DNA in the cells make protein. And this is what happens on the right. There's this gray cell here, which is a normal cell. And it goes on about its business, multiplying and giving rise to more normal cells, each of which looks like its parent cell. Now, what happens when there's cell damage, and how do cancers develop? And there may be some kind of initiating damage. This may be chemicals, this may be radiation, this may be viruses. There are many things that can damage a cell. And essentially what happens is that when there is damage to the cell, we are talking about damage to the DNA. So if there's damage to the DNA without killing of the cell, then that cell with its damaged DNA can go on and proliferate. And cancer, as you know, is not just a one-step thing. You don't wake up with a normal cell one day and then the next day you have cancer. So it is multiple mutations that occur in a cell that is already damaged, and this damage is irreversible, and this cumulative accumulation of damages within the cell will ultimately lead to a cancer cell. So what I'm trying to say basically is that, as has been emphasized before, cancer is a disease of the genome, all right? So it is actually a broken cell. And there may be switches that are thrown that are different to that of a normal cell. Different types of wirings are present, to keep it very simple, that allows the cell to have a growth advantage. And what we are trying to do when we are trying to make precision medicine a reality and we are trying to do molecular testing is that we are trying to find what the molecular defect is. And if we find what is making the cell the way it is, if we can fix what is broken without harming normal cells, then that is the basis for precision medicine to actually be deployed. So I want to just basically talk a little bit about the cancer treatment then and now. And for the longest time, the way we treat cancers is either by cutting it out, by poisoning it, or by burning it. So, and these are some of the effects of chemotherapy. I think all of us have either had friends or family members, and in my own family, of course, we've had members. I've had members of my family, and it was actually quite a horrible thing to watch them. But that was the truth. In the 60s and the 70s, there really wasn't any of the kind of wonderful targeted therapy measures that we have now. The problems of chemotherapy also is that it is not targeted, and therefore not only does it kill the cancer cell, it also kills healthy cells. It kills rapidly growing cancer cells. So the slow growing tumor cells are probably not as effectively killed by chemo. They're also very unique cells called cancer stem cells, and chemotherapy, we know, doesn't actually act on the cancer stem cells. And the truth is that unless you kill the cancer stem cells, the cancer can come back. And finally, of course, we've all seen how cancers can predispose to infections because your immunity is demolished. And that's not something that we want to do. We want to keep our immune responses intact so that they can be called to the fore to fight the cancer as well, together with whatever therapies that we are instituting. So there is, of course, hope. And this hope is cancer treatment now. So we've not done away with surgery or chemotherapy or radiation, but today we are going to talk a little bit of targeted therapy, and I won't talk anything more about immunotherapy because Matin has touched on it and it's a whole nother topic. So again, keeping it very simple, I have on the left chemotherapy, and if we are talking about the yellow center as the target, chemotherapy drugs actually are aimed at a particular cancer or a target, but not all of them will hit it. A lot of them will miss. Some of them will lie on the ground. Whereas with targeted therapy, not all of them are going to hit the target, but depending on how precisely you have identified the target and how good your drug or your targeted therapy is, the chances of hitting the target is far better than with chemotherapy. So again, if I can use another analogy, on the right, you have this huge battleship. So if your target is really huge or you don't know what your target is, then you have to use a really huge bomb, maybe even a cluster bomb to destroy the ship. But if you know what your target is, then you can use a sniper rifle and just precisely target that cell without harming the cells on either side of it. So that is perhaps another analogy that I can give you about how targeted therapy works. So on the top, you have conventional therapy, which is like chemotherapy or radiation or whatever. Or you may have a pill that may give you only a 30% response because you are selecting all patients with a particular disease type. Whereas if you have a technique which can identify a patient with a particular type of tumor, and based on the information that you get, you can now prescribe a prescribed prescribe a precise treatment, then the response is better depending on the type of cancer that the patient has and the type and the efficacy of the type of drug that is being deployed. Okay, so we have all heard about Dr. Murali's analogy when we say that everybody in your family is different, and with each of you having your own flavors of nasi lemak and nasi lemak stalls that you enjoy. Similarly, not only is every person different, but every cancer that occurs in that individual person is also different. So we are dealing with a multiple of variables, and therefore it becomes very important to be very careful about the kind of treatment we institute. And this is made possible by molecular profiling. And I will talk to you a little bit about what is referred to as comprehensive genomic profiling, sometimes referred to as CGP. It's also known sometimes as next generation sequencing. They mean the same thing. Or sometimes even in the literature, it's referred to as massively parallel sequencing. So what do these terms actually mean? We'll talk about it. So this is just a cartoon, and that's probably Dr. Matin down there asking me what the diagnosis is. And of course, this light microscope, we're never going to run away from it. It's always going to be there because it's the first tool that we use to make a diagnosis of cancer and also to tell the oncologist what type of cancer it is. But we need to move ahead because, as I've established, cancer is a molecular disease. So we need to move away from just looking down the microscope and calling it breast cancer or colon cancer or liver cancer. We need to do more. We need to see whether there are any molecular targets. As we know, every cancer is a molecular disease. Are there molecules inside that are deranged, that are abnormal, that are broken from that of the normal cell that we can now fix because we have drugs that can target those molecular aberrations. So the new paradigm is we have a cancer patient, the clinician will take the history, they go for all those various tests, they eventually will have a biopsy, and then where we used to stop here and start treatment, we now go on to doing other things like molecular pathology and looking for targets so that targeted therapy, very precise targeted therapy for a particular cancer can be instituted. And that's the promise. Not always are we able to fulfill the promise, as Dr. Matin has said, but nevertheless, our intentions are pure, and this is what we are trying to do. So some of the samples that are available, traditionally, we've always used biopsies, tissue biopsies, where a needle is passed into the organ which harbors the cancer to take out some tissue for the pathologist to look at, and then in an appropriate situation to go ahead and perform molecular profiling. But more and more, Dr. Matin already alluded to this, we have liquid biopsy, where we can actually take the blood in cases where it is not possible to do a solid tumor biopsy. We can probably, at least for some type of cancers, take the blood and analyze it for the same kind of mutations that we are looking for in the solid tissue. And why is this possible? It's because when these tumor cells grow, they die, and when they die, all that genetic material is spilled into the blood, and it's circulating in the stream. So we have now techniques that are so good, that are so precise, that are so refined, that even if we find one cell in 100, one tumor cell in 100 normal cells, we have techniques in place which can actually help us identify those cells or those abnormal fragments of DNA. So for some types of tumors, tissue is at a premium. For lung cancer, for example, most patients will arrive very late in the stage of the disease, and a biopsy that is done may have maybe 100,000 cells. If you're lucky, sometimes only about 50 cells. Now, imagine if you are trying to look for all the possible driver mutations in those 50 cells. After doing the third test, you probably will run out of tissue. So enter this new technology which is called next generation sequencing or comprehensive genomic sequencing, where instead of going and doing everything one by one and at the end of it, depleting the tissue and then having to go back and re-biopsy or perhaps do a liquid biopsy, we can right at the front, after establishing that it is cancer and that it is from a particular kind of organ, we can take away that sample and quickly put it into a machine that within a fairly short period of time will allow us the luxury of looking at a very wide panel of mutations. And for lung cancer, we have a machine that can look at 50 genes that are driver mutations for lung cancer, and we can return a result within 3 days, which is really a game changer when you used to take months, sometimes using this kind of sequential approach before you ran out of tissue or before you got a result. So I've alluded to the fact that our techniques now are becoming so precise that if you have, this is at 15% sensitivity, right now we are at 1% sensitivity. Basically, if you have one cancer cell in a population of 100 normal cells, we have techniques now which can actually pick that up. And actually the envelope is being pushed. We can now have digital sequencing technologies that can go down and pick up one cell in a background of 1,000 normal cells. And that's really, really a very, very sensitive technique. And the beauty is that it's also very specific. So again, just to give you an analogy, if you have one tumor cell like this colored fellow here, in a population of normal cells, which are all this nondescript, very normal looking cells, we can pick you out. As the movie goes, Liam Neeson said that I will find you and I will kill you. So that same kind of principle basically operates. So we have moved now from single gene testing to multiple gene testing. And this is what next generation sequencing or massively parallel sequencing does. Again, if I can give you an analogy, single gene testing would be something like having a dial-up line for your internet connection, where you probably can do a download of a movie, and that might take you 4 or 5 days if you have a slow dial-up connection. Whereas a massively parallel sequencing means you have a huge broadband connection where you can do multiple downloads, and you can download a Netflix movie, say, within about half an hour, as opposed to days. So I hope that's the kind of processing power that we have with a next generation sequencing, where we can sequence multiple genes within a short period of time, all at one go. And we have panels now that can look at up to 600 genes from one tissue sample. So this is the workflow. We can either take your tumor tissue or your blood. We can run it through a pathological review, which is important, looking down the microscope again, just to make sure that you have cancer, to make sure that the cancer is a particular kind of cancer. And then we go through a number of steps, go through a machine, and then we do a genomic profiling. And then there's a lot of complex bioinformatics information because there's this huge amount of data to sift through. So we need to have a person who is an expert in this field to curate all of that data and sit with the physician or the pathologist to generate a meaningful medical report to decide what are the important driver mutations and which are basically just garbage that are not going to be useful as far as the patient's cancer is concerned to identify targets for therapy. So just a few more slides left. So this is where we are at now. So when the patient comes, they are normal, and then they get disease, they have clinical symptoms, and then they go to a doctor, and if the treatment is effective, they get better. And then if the cancer comes back, you know, we can, the curve rises again. So most of the time, we are treating patients above this dotted line. They have to come to the hospital, they have to lose weight, they have to cough blood or do something like that before we decide or detect their cancers, by which time for some types of cancers it's already too late. So the promise of this technology is that we are now going to be able to detect patients who are normal and healthy, but who have cancer predisposing genes or who are asymptomatic. We should be able to pick them up early. Or we have patients with cancers who have now been treated and have no more clinical symptoms, but they're cancer cells that are lingering there, just biding their time to develop resistance and then to resurface again as perhaps a more aggressive tumor. So using these genomic sequences, sequencing technologies in place, by having the ability to look at solid tumors as well as blood, we are now able to again expand the scope of our testing and pick up patients who have very early disease or who are having very early relapses or recurrences. And with this hope, we hope that one day we will be able to eradicate cancer, not perhaps in the immediate future, but certainly we are heading in that direction very, very quickly. So these are my take-home messages. That first of all, I hope that you understand that now cancer is a molecular disease, and that we are trying to identify the biomarkers because these biomarkers, which are predictive meaning that they can tell us what drugs work best for this particular cancer. And these are important steps that we take to help in defeating cancer. Next generation sequencing allows us, through a massive processing power, to look at a small sample of tumor biopsy tissue or even blood to identify important biomarkers very, very quickly without a minimum of fuss. And these technologies are getting cheaper and cheaper. And at our hospital, as some of you already know, we do provide this as a service under several programs. Some of these are sponsored by pharma, so it's nowhere as expensive as it would be otherwise, or as it used to be. Liquid biopsies are becoming important. Some patients are just too sick to be biopsied, or may have the tumor come back in an area which is almost impossible to biopsy without harming the patient. Then liquid biopsies are certainly a very good option. Liquid biopsies cannot be done for all cancers, but this again is changing, and soon it perhaps will become possible for a wider spectrum of tumors. Right now, we have good liquid biopsies for lung cancers and breast cancers, which are among our commonest cancers, and also for colon and prostate cancers. But as I've said, that list is expanding. And finally, next generation sequencing promises to be a game changer because it not only addresses the problem of disease that is coming up late, where you are struggling to identify a targeted therapy, but it's also going to become important for cancer screening, for detection of early cancers. And now there are important trials to show that identifying mutations in very early stage cancers can again be perhaps our best chance of eradicating cancers. All the while we were focusing on identifying biomarkers for late stage cancers because we used to think that once you surgically resect these tumors, that is a cure. Now we know that it's not true. For example, in lung cancers, even the stage 2 cancers or the very early stage cancers, it's been shown that they can actually benefit from targeted therapy if a driver mutation can be identified. And again, as I've said, even after the cancer has been treated, we can use these technologies to continue to monitor, to ensure that you remain disease-free and cancer-free. And if that cancer decides that it wants to come back, then using these technologies, we hope to be able to detect it early and when the tumor is still small, so that we can quickly swing into action and precisely target that small volume cancer cells, and therefore, hopefully, our chances of success is better. Thank you very much.
Thank you so much, Prof. I think you very kindly made possible for our audience this entire big, huge packet of information, and you've made it very simple and relevant to them as well, Prof. Thank you so much for that. We can take some questions, Prof. Is that okay?
Sure, of course, yes.
Okay, lovely, Prof. There's a question on, and I think you have spoken about Subang Jaya Medical Center as well, but there's a question, I think, generally, where else is genomic profiling available in Malaysia?
Okay. In Malaysia, there are a number of hospitals that perform genomic profilings. Many of the private hospitals do it. And in the Ministry of Health, some of the hospitals do genomic profiling, but not comprehensive genomic profiling or NGS. They do single gene testing for common cancers, such as lung cancer. And for breast cancers, I think there is also an initiative to look at BRCA testing in some of the Ministry of Health centers of excellence.
Right. Prof, I was going to kind of carry on the question. I think some of the questions which Dr. Matin kind of deflected over to be fielded by you. Prof, there was one question on, I think, the use of now liquid biopsies for patients who previously say it's recurrent cancer 10 years ago, and when they had no opportunity to kind of undergo the testing at that point in time. Is there an availability of liquid biopsies for them to do now?
Yes, I think I mean, generally the kind of cancers that recur after 10 years, because you mentioned 10 years, these tend to be the breast cancer patients. So yes, there are liquid biopsies available, but often the receptor testing is best done on tissue. Whereas liquid biopsies are better for looking at newer molecular targets. We know that there are molecules such as the PIK3CA molecule, which can be tested, of course, on tumor tissue, but if it can't, then liquid biopsies can actually be deployed for this. And this is particularly useful in patients who have had hormone receptor positive breast cancer and who have now relapsed, which means that the hormone therapy isn't working anymore. And we know now that there is another molecule called the PIK3CA, and when that is deranged, then it confers a relative resistance to hormone therapy. So there is a drug out there in the market that is available in Malaysia, which can be used to target these patients, provided they have a PIK3CA mutation. So that's how targeted therapy and genomic profiling is helping to change the landscape of recurrent breast cancer.
Right, lovely, Prof. And this, the next one is really like a role question on the role of the pathologist. And this is, I think Dr. Matin was speaking to it a little earlier. You spoke to it a little yourself, and kind of how, because for a lot of people, you can't seem to see the role of the pathologist. They're very hidden behind the scene. You get a printout, and then there's a name on it, and then how deeply involved would you say, Prof, is a pathologist in kind of helping this patient figure out a diagnosis and reach like a management?
Okay, so actually the onus of responsibility, I would think, is on the patient, because we don't meet the patients directly. The pathologist is like a consultant to a consultant, and our customers, so to speak, are the oncologists and the other clinicians. So we don't deal with patients directly. The only perhaps exception is when the pathologist may be doing a fine needle aspiration of a breast lump or a thyroid lump or something like that. So I'm very open to discussing results with the patient if they want to discuss pathology finding or even a genomic profiling report. But I try not to do it upfront. I would rather that the patient goes and speaks to the primary physician first, and then come and see me, because that's in my opinion the protocol. Sometimes patients will come with a referral letter because they want a second opinion. They've been referred from another hospital by the oncologist, and material has been given to them, and they bring it. In such an instance, yes, I would actually speak with them. But in other circumstances, if there is no formal referral, I would rather that they get the result, the pathology result from the referring physician. And if after that they still have further queries, then I'm happy to meet with them. So I think most pathologists are open to this, especially pathologists practicing in hospitals or in a hospital environment. I think some of the pathologists who practice in a private laboratory setting may not have the facility, or the patients may not have as ready an access to them as in a hospital environment.
Right. Prof, and kind of this is, I think, again, a question which I seem to keep bringing up, because it's something that we cannot stress enough. And to patients, Prof, who often have a difficult choice to make, in the sense that is this money worth spending? In terms of, should I go and do a complete genomic profiling if it's so advised? Should I go and do this immunohistochemistry, these additional tests? Could I really get some words of wisdom from you to help advise them?
Okay, so I typically will not order immunohistochemical tests until I have seen the pathology under the microscope and have made the decision that I'm going to have difficulty deciding exactly what sort of tumor this is or where it's coming from. It's only then that I would do or request for immunohistochemical stains. Now, there was a question that was raised earlier, why don't you do all the tests upfront? Now, if you do that, there's a lot of unnecessary expense to the patient. And to me, that is not the good practice of medicine. Basically, it's almost like a blunderbuss approach where, you go and see somebody for pain and you end up getting vitamin tablets and all kinds of stuff. So I would prefer to adopt a scientific approach and, proceed in a stepwise manner that would be the least wasteful for all parties concerned, including the patient. There is not unnecessary expense. And insurance companies now are also querying as to, why all these tests were done when actually we could have made do with just 2 biomarkers instead of 10. So I think we are all very alert to the economics of the situation, to sensitivities from the insurance companies, and also the wallet of the patient. So where it's absolutely necessary, I think it's important, because without a precise diagnosis, you cannot institute a precise treatment. So correct diagnosis, correct drug. So that's basically why we need to do immunohistochemistry. For genomic profiling, some tumors where there is no real target, I really wouldn't advise that every patient have genomic profiling done. For lung cancer, yes, I would certainly do that if it was a primary adenocarcinoma, because there are so many driver mutations and so many good drugs out there. And they are, as Matin said, we have stage 4 lung cancer patients who are long survivors, where previously they used to, the demise, they would go quickly. So there's certainly a need for us to maximize that tiny bit of biopsy tissue to get as much information as possible, so that in the hope that we can actually get a driver mutation that can be targeted by one of the drugs out there, and therefore improve patient quality of life, progression-free survival, overall survival, and all the rest of it.
Thank you so much, Prof. And as we kind of okay, there's another question. Are there any specific guidelines under which they actually request for an NGS?
Yes, I mean right now for lung cancers, that is a straightforward request, because there are so many driver mutations out there. To go in a sequential manner, you will never be able to detect all the possible driver mutations. And through our own program that we have initiated, we are finding mutations that we would never have been able to find before if we were to just do single gene testing. When we test for EGFR, it's negative, then we test for ALK, and then it's negative, then we go to ROS, and it's negative, and then that's it. Whereas this way, we test for everything. So because of NGS, we have picked up patients. We had our first RET fusion. We've actually been looking at lung cancer for the last 4 years. We've never had a RET fusion. But within a couple of months of starting NGS, we picked up our first RET fusion. And these patients respond exquisitely to targeted therapy. Similarly, we have so many other mutations which would never have been detected, like MET exon skipping, MET amplification. Because by the time you get to MET, you would have exhausted your tissue. So that way, next generation sequencing has been a game changer for us. It has allowed us to give the best possible therapies through technologies that are able to identify these mutations, which are rare. I'm not saying they are common mutations, but for the patient, it is a world of a difference.
Yep. Exactly. So thank you so much, Prof, as usual, for your exciting insights, and I think the lovely way that you share them as well. Such a pleasure having you with us this evening, and I hope, ladies and gentlemen, that that you all get as much information as you did. Feel free, in case I did not kind of mention it, is that this session is also kind of archived in Subang Jaya Medical Center's Facebook as well as ours. It's in the video segments of both our centers. You can go back and take your time and rewatch and kind of go through these learnings as they have been shared. Thank you so much. Thank you so much, Prof. Have a wonderful evening and see you soon.
Thank you. My pleasure. Goodbye, everyone.
Ladies and gentlemen, that was Professor Dr. Pathmanathan Rajadure, consultant pathologist at Subang Jaya Medical Center. And the third speaker for this evening is a consultant hematologist. And we're especially privileged to have Dr. Alan Hean. Good evening, Dr. Alan. How are you?
Good evening, Dr. Murali. Very pleased to be here.
Such a pleasure to have you with us. And ladies and gentlemen, as you probably know, this is an exciting kind of moment as well. This is the first hematologist we've had on for the entire Cancer and Eye series. So feel free to shoot any question that you have at Dr. Alan. He'll be very happy to kind of answer any queries that you may have. Dr. Alan, thank you so much for joining us this evening. And hematology really is sometimes, I mean, for us in the world of cancer, it seems to be another universe. Simply because we quite often focused on the solid tumors, we kind of give the hematological malignancies a kind of a drive-by shooting kind of idea. So it's very good for us to have you this evening to share with everyone on hematological malignancies, especially in adults, and the precision medicine pertaining to that. I will turn over the screen right away to you, Doctor.
Well, thank you, Dr. Murali, for having me. And I'd like to thank the National Cancer Society for allowing me to share some things about precision medicine in hematology. So I think it's a very broad field, so it's very difficult to cover everything. I just hope to give some examples, and my colleagues have already spoken about the technology, especially Prof. Patna. So I think what I want to do is something a little bit different, maybe a little bit more patient case example, patient-centric examples of precision hematology in action. Okay, so as far as hematology is concerned, I mean, the advances in medical science has enabled us to be more precise in the way we make diagnosis, in the way we can prognosticate. That means we are able to predict how well the patient is going to do, and to some extent, also more precise treatment. Okay, rather than the old treatment modalities, we now have targeted treatment in hematology in many cases. Okay. As far as diagnostic tools, you remember the mammoth and the microscope, which Prof. Padma showed. A lot of us still will have to go through the traditional morphology, which is the appearance of the cancer cell under the microscope. And being liquid cancers like leukemias, the biopsy is very simple. In most of the time, the initial one is through a blood sample, and we can actually determine we are dealing with a blood cancer. The flow cytometry or immunophenotyping is where the blood is, or marrow sample is passed through a machine, and then markers are applied, and we can identify what type of malignant cell this is. And cytogenetics are still done and are still relevant. And this is whereby chromosomal mutations and abnormalities are detected on the blood or marrow sample. But I think everyone has heard of PCR now with COVID, where the term is being used very frequently now, where the abnormal gene mutations are amplified by this technique, or by FISH, which is another technique to identify gene mutations. And lastly, where you want to analyze multiple genetic abnormalities, we now have next generation sequencing, which my colleagues have alluded to. Okay, I think rather than bore you with the technical aspects of all these, let's go through some case examples to see precision hematology in action. So there's this 60-year-old woman who came in with very, very elevated platelet counts, and this is what the blood count showed. So the hemoglobin was normal, 12.6 grams per liter. The range is about 12 to 16. And the platelet count was extremely high. Okay, the normal platelet count is 150 to 400 times 10 to the power 9 per liter. And this patient had a platelet count of 1152. And the white cell count was slightly elevated. So this patient came for a second opinion because she was diagnosed to have essential thrombocytosis in another center, but she was also very reluctant to undergo a bone marrow biopsy to clearly establish the diagnosis. And essential thrombocytosis is one of the myeloproliferative neoplasms where the bone marrow pushes out a lot of blood cells, either platelets, white cells, or red cells. So we said there's no two ways about it. You will need more detailed tests, including we can't run away from a bone marrow biopsy in the MPNs or myeloproliferative neoplasms. So she had the traditional bone marrow biopsy, chromosome analysis, PCR, but she wanted a very detailed testing to exclude any other possible mutation. So to sort out whether this is indeed essential thrombocytosis or not, we did everything: cytogenetics, PCR, and NGS. Normally we will not do, but there are some practical problems too. I mean, like Prof. Mother say, we don't want to do NGS because it adds into the cost, but sometimes costs are not covered unless it is under insurance when the patient comes in for the procedure. If you want to do it later, then the cost may not be covered. But lo and behold, we found that this patient had the BCR-ABL1 mutation. Actually, this is the mutation seen in chronic myeloid leukemia. And later on, when the chromosome analysis came out, she had the typical Philadelphia chromosome. Okay, this is a very short chromosome number 22, which is the result of unequal breakage and joining between chromosome 22 and 9. And now we know that the gene fuses between these two, the BCR gene and the ABL gene, which gives rise to an abnormal tyrosine kinase. And this is what drives chronic myeloid leukemia. And this is actually probably the first example of precision medicine in cancer, where you have a precise diagnosis. We are able to identify the driver mutation which causes the leukemia. And nowadays we have precision treatment, which is a tyrosine kinase inhibitor for chronic myeloid leukemia. Then nowadays there are quite a number: imatinib, nilotinib, and dasatinib. And these patients do fabulously well. You know, in the past, we only had oral chemotherapy, like hydroxyurea, and we had to do bone marrow transplants for those who are eligible. But even then, we could cure only about 70% of patients with CML with bone marrow transplants. But nowadays, with targeted treatment, we can do away with this. And if you respond, over 90-95% of patients are alive and well at over 10 years. And many of them are medically cured. And some can even now possibly go off the drugs, provided they remain totally negative. The BCR-ABL level can drop to 0. And in some instances, the hematologist may be able to stop the drugs after some years. So this is the prime example of precision diagnosis and treatment in hematology. And I think it paved the way for a lot of work in oncology. Okay. And this is another interesting case where this woman had actually headaches and had visual disturbance, and she's found to have sagittal sinus cerebral vein thrombosis, which is actually a blood clot in the brain, which gives rise to increased pressure, the headaches, and so on. And the blood counts were abnormal. She had a very high hemoglobin, meaning she had a lot of red blood cells. The platelets also were high, and the white cell count was just about normal. The clinicians suspected she had a myeloproliferative neoplasm, and we thought whether she did have polycythemia vera. So most of these patients would have a peculiar mutation in the JAK2 gene, okay? So the mutation is called the JAK2 V617F mutation. And we will first of all do this by PCR technique. And vast majority will be positive, but in this patient, she had no mutation detected in the V617F analysis. So what we did was to request the NGS myeloid panel, and lo and behold, she had a much less common mutation detected by NGS, and that's on the exon 12 part of the JAK2 gene. So she indeed has polycythemia vera, but not the common V617F mutation, but a less common exon 12. Sometimes we see other less common mutations like the calreticulin or MPL gene, and you can see there are lots of other gene mutations which can be detected in various types of myeloid neoplasms or myelodysplastic syndrome. And having diagnosed polycythemia vera, we could confidently say what she needed was a therapeutic minisection, where actually we take out the blood, thin it out, and she needed anticoagulation because of the blood clot in the brain. And being a myeloproliferative disorder on neoplasm with a clot, she's at high risk of developing further clots. So she actually needed hydroxyurea to reduce the counts of both the platelets and the red cell counts. This is not by itself targeted treatment, but it's still recommended treatment because it's highly effective. We do have targeted treatment in the form of JAK2 inhibitors, but they are not only restricted to very difficult to control polycythemia vera patients. Okay. And the third and last case I want to show is an older woman who presents with fever and flu-like symptoms, and actually she was found to have very abnormal blood counts with anemia, low hemoglobin, slightly low platelet, and a grossly elevated white cell count with over 200. And the normal is 4 to 11 times 10 power 9 per liter. So this is 200. It was very clearly leukemia because the blood and the marrow had mainly blasts. Okay, under the microscope, we could diagnose acute leukemia, which looked like myeloid blasts. Okay, but that's not precise enough these days. We still need a more precise diagnosis. Okay, not all AML are the same. There are different One of the things we can do is a flow cytometry, which the report looks like that. So these are all the different markers which are indicative of myeloid leukemia of the monocytic type. But precision hematology doesn't stop there. We need to analyze the chromosomes because this guides us on to determining the more for prognosis. So, we have patients with AML who have normal chromosomes, abnormal chromosomes which bear good prognosis, and abnormal chromosome which bear poor prognosis. Unfortunately, this patient had multiple translocation and structural abnormalities involving the odd-numbered chromosomes. So these are usually corresponding to very poor prognosis. Okay. So multiple cytogenetic abnormalities in this lady, unfortunately. We also managed to do an NGS AML panel. And the purpose of doing this is to try to identify any mutations which can be targets for treatment. Okay, and one of those which we always look for is the FLT3 ITD mutation, which was detected in this case. So by itself, this would be a poor prognosis, but at least there is some target for therapy for those AML patients nowadays with the FLT3, FLT3 mutation. She also had, unfortunately, a mutation in the tumor suppressor gene. So this gave her double reason to have poor prognosis. In the elderly AML in the past, we would say a lot of them are 70 and above, would be mainly for palliative care. They can't tolerate intensive chemotherapy. Nowadays, we have more targeted treatment in the form of hypomethylating agents. A lot of AMLs in the older population arise from a background of myelodysplasia, where a chemical process called DNA methylation is excessive. So providing a hypomethylating agent together with a targeted treatment called a BCL2 inhibitor, and the drug name is venetoclax, has been shown to produce remission rates almost as high as standard chemotherapy. But having a FLT3 inhibitor, we can nowadays add in, having FLT3 mutation, we nowadays can add in a FLT3 inhibitor like sorafenib or midostaurin. So it is not just blunderbuss chemotherapy, but we are able to provide more precise chemotherapy to produce better responses in even elderly patients. Okay, I think with this, I don't want to bore you with even more and more examples. I just want to show this pictograph. This picture from Instant Oncology to how to decode cancer drugs. When your doctors tell you what we have this targeted treatment. There's actually a generic naming formula, okay? And you realize a lot of them have this common endings. So if it is a tyrosine kinase inhibitor, it ends with tinib. So like sunitinib, imatinib, nilotinib, all right? If it's a proteasome inhibitor, it ends with zomib. So like bortezomib used to treat myeloma. Okay, then these are more oncology drugs. So if it's a CDK inhibitor, then it ends with ciclib. A PARP inhibitor ends with PARP. BRAF inhibitor ends in rafanib. Okay, and then you have the monoclonal antibodies. So whether it's a humanized mouse antibody, then it ends with a Zumab. If it's a fully human antibody, it's a Mumab, and it's a Zimab if it's a chimeric mouse human antibody. For example, we commonly use a drug called rituximab, which is an anti-B cell antibody. So that targets TU, and it's a chimeric human mouse antibody. So it's CMAP, so rituximab. Okay, and we have obatumumab, which is fully human anti-CD20 antibody, and like polatuzumab, which is anti-CD79 humanized mouse antibody, and so on. So I found this one quite useful, and some of my colleagues also found this quite useful to decode the secret formula used to name your targeted therapy. Anyway, with this, I just want to stop here, and I'll be happy to take any questions. Thank you.
Oh, thank you. Thank you so much, Doctor. That was, I think, especially the last slide, that was very, very helpful. A lot of people have a lot of problems wading through the alphabet soup of drugs. Hopefully this manages to give them a little bit more kind of clarity on what all these different IBs mean.
It's like Greek. Oh, I've got another slide here, if you don't mind, because I'm surprised nobody's asked. Is it still screen sharing? Many hematology patients are asking, can we have the COVID-19 vaccination? This is not, I don't know whether you've covered in your other sessions, but I just want to show. Notice all the check boxes are checked. All the boxes are checked. Yes, the vast majority boleh terima vaccine COVID-19. Okay.
Sorry,
leukemia.
Doctor, I think we lost the screen share, Doctor.
Oh, okay. Sorry. Let me see. One more time. I may have to reshare it again. Sorry. The Zoom share screen has died. Okay. Got it? Is it showing? Yeah. Sorry. Yeah. So all the patients said, bolehkah saya terima vaksin COVID-19? This is for hematology patients. So the Malaysian Society of Hematology has come out with a consensus statement. So majority of patients, yes, some with conditions, okay? So generally, if you certainly have a previous lymphoma, leukemia in remission, you can. If you had a bone marrow transplant, but not recently, at least 3 to 6 months ago, answer is yes, you can. Cancer chemotherapy, generally, this one a little bit you have to discuss with your doctor, depends on how intensive and the type of treatment you have, but many patients can have, provided the treatment doesn't blunt their response to the vaccine too much. Okay, patients with ITP, provided the platelets are not too low, where you worry about bleeding because it's an intramuscular injection, autoimmune hemolytic anemia, thalassemia, G6PD, splenectomy, PNH, hemophilia, again, all worry about bleeding, and you're on anticoagulants. And generally, yes, you got to press very long for at least 10 minutes to stop the bleeding. Okay, and that goes for antiplatelet agents as well. So all the boxes are checked, some with some conditions, okay, but best discuss with your doctor. So that's just, I wanted to share that before anybody asks, can I have the COVID vaccine? Because almost every patient is asking that.
Yeah, absolutely, Doctor. And ladies and gentlemen, if you got this on a phone, screenshot, and then you'll have it to kind of digest later at your own kind of convenience. Thank you so much for that, Doctor. I think because especially in hematology, there's been a lot of queries on whether people can or cannot receive the vaccine. There's been quite a lot of debate on that.
Okay. All right, happy to take any questions. Yeah, thanks.
Oh, lovely, Doctor. There's a couple of questions. I think the first one, I'm just going to kick this off, kind of moves away from precision, but I think it's covering hematologic malignancies. Is there a targeted therapy for multiple myeloma?
Oh, definitely. Nowadays, the treatment for multiple myeloma consists mainly of targeted therapy. When I started my training in the 1980s and the 90s, we only had chemotherapy using drugs like cyclophosphamide, penicillin, melphalan, prednisolone. Melphalan is now like 70 years old chemotherapy. They are still used to some extent, but in those days, the average survival for myeloma patients was something like 2 years or 3 years. And when we measure myeloma, we measure something called the paraprotein level. And we said remission means the paraprotein level drops to 50% or less, and we're very happy already. But I think things have changed so much in the last over 30 years now. We are able to give purely non-chemotherapy treatment to multiple myeloma. So the anchor drug, which is targeted against the proteasome, what we call proteasome inhibitors. The first one is Velcade, all right, which is the first proteasome inhibitor, has changed the landscape of myeloma treatment. So we've increased the remission rate. Nowadays, they're combined with at least 2 other drugs, so-called triplets. So we can combine Velcade with lenalidomide and dexamethasone, for instance. Remission rates are very high nowadays. And we are talking about remission not dropping to less than 50%, but dropping to very low levels and sometimes down to 0. Okay, and it translates into better cure. Not cure, but better survival. I think we still can't truly cure myeloma, but the prolongation of life and quality of life is much improved than compared to 30 years ago. So we do have patients living, the average survival is more than triple, from 2 to 3 to 8 to 10 years, and some patients are alive and well 15 years and beyond. I've got patients remaining in apparent complete remission after 15 years still. But this is a combination of treatment, targeted treatment, autologous bone marrow transplant, which is still used, okay? And even if patients relapse now, we cycle them through different types of targeted treatment. But it's a challenge. Myeloma is still challenging because we're dealing with the older population, and the treatment needs to be tailored according to the individual, according to what the patient can tolerate, kidney function, etc.
Right. Doctor, there's another question on, may I know, okay, for a patient diagnosed as ALL, after starting on their maintenance therapy or maintenance period, should they be still able to have a bone marrow transplant?
Bone marrow test, I saw that. Is that
bone marrow
test?
Yeah, sorry. Yeah, bone marrow test. Sorry.
I think we may need to sometimes repeat the bone marrows in a course of therapy if we want to be certain the patient still is in remission, or if there's a concern about relapse while the patient is on maintenance. So sometimes if the counts drop and then don't pick up despite stopping your maintenance drug, sometimes you're concerned whether the disease has come back. So we do often require a repeat bone marrow. Okay, so bone marrow is nothing to be afraid of. I think a lot of people are scared of doing bone marrow biopsies to this day. It's like taking a blood sample, but we are taking it from the marrow. And if done properly, it is not very painful. Okay, we do it under a bit of sedation, local anesthetic, so it's a daycare procedure. I think if the doctor gives the local anesthetic, waits enough time for the local anesthetic to work, and I think that's the key, because maybe some young doctors are in a hurry, jab the local anesthetic and then jab the marrow needle quickly, it will hurt. But if you instill local anesthetic, wait, 2 minutes, 3 minutes, then only put in the marrow biopsy needle, it shouldn't hurt very much. Okay. So yes, we often do multiple marrows in the course of treatment for a patient with acute leukemia, at diagnosis, to assess remission and to assess response, and to look for minimal residual disease, and pre-transplant, post-transplant, and so on. Okay.
Okay, got it, doctor. There's another question from a patient. I think this was on stage 4 prostate cancer patient with frequent blood transfusions. Any idea on increasing the production of hemoglobin?
Blood transfusion is still the mainstay. I mean, the question is, can you use erythropoietin stimulating agent in malignancy? This is a little bit controversial, Dr. Murali. I think there are some studies that use of these ESAs may have a negative impact on the cancer. There may be a negative impact on survival, increased risk of thrombosis or blood clots in such instances. So while there are drugs which may help increase the hemoglobin by stimulating red cell production, they also may have negative impact. So best discuss with your oncologist. Yeah.
In an individual setting, doctor.
Yeah.
Doctor, there's, and I think how to say, we see a lot less awareness among older people in Malaysia about hematologic malignancies. There's not many things that come out on what are signs to look for. But even for me personally, I think over the past month, we've been referred about 5 or 6 people who tend to kind of been either picking up late leukemias or lymphomas, even multiple myelomas. Is there something that people should be doing? Is there something that people should be looking out for? Any advice?
I think it's awareness, and early detection is possible. For example, lymphomas. Often we see patients come late because they may have an enlarged lymph node, but they're afraid to go for the biopsy. They delay until the lymphoma spreads. Then they are in a more advanced stage, and the cure rates drop in the more advanced stages of lymphoma. For leukemias, there's no routine screening. You may pick it up, but again, some of the early symptoms of acute leukemia, like the patient example I showed, may be very similar to viral illness, flu-like symptoms, fever, sometimes body ache. Okay, but very often blood tests are done. So I think the seeing your primary physician, your GP, and getting a diagnosis, and if they suspect something is not quite right, early referral is always appropriate. So somewhat different from solid tumors, where you have good screening programs, they are for early detection or prevention. But for hematologic malignancies, it's understanding what to look for and when to refer, as far as the primary care practitioner is concerned.
Yeah. Right, got it, doctor. And in terms of are there things that we can do to kind of reduce our risk of hematologic malignancies? Anything above and beyond the usual kind of diet, exercise?
Yes. Well, everything we go through, what we would like to do in terms of blood tests, PCR, molecular tests, we tell all these patients. At the end of the day, the patient will ask us, and so, doctor, what can I eat and cannot eat? You get that question, and the response is something like that. I think it just focuses. I mean, it just tells us our patients are still, their daily lives matter. But I tell all my patients, don't smoke, don't drink. They ask me why I get a cancer, and what do you think the consequence of smoking all these years would be? There is a link with not just lung cancer and other cancers with cigarette smoke, but even like Hodgkin's lymphoma is associated with cigarette smoke. We are talking about myeloma and so on. So I think when you have these acquired mutations in your genes, and there are a lot of things in our environment can do that, but I think it's basically healthy lifestyle. Yeah. So yeah.
Right. Dr. I think there's one more question if you were able to take it. This one is on are there circulating biopsies I think liquid biopsies that can be done for hematological malignancies rather than doing a bone marrow?
Well, the liquid biopsy is taking the blood sample, so it's and we can do flow cytometry on blood and molecular analysis, but we can't run away from marrow biopsies because at least in the diagnosis, we will need to assess the cellularity of the bone marrow. So some types of leukemia may be associated with a hypocellular marrow, which will tell us about the marrow reserve, and there are more gross appearance in the trophine biopsy as compared to just the aspirate. For the MPNs or myeloproliferative neoplasms, without the biopsy, you can't tell whether there's any myelofibrosis, for instance. So, I mean, we can't run away with the bone marrow. Okay, but yes, I mean, blood sample can be done in many instances, but for full assessment, usually at least at the beginning, at the diagnostic stage, we would require a bone marrow. Mm.
Lovely. I kind of missed out on that earlier, Doctor, and I think you kind of very rightly pointed out that this whole story of precision medicine actually started with hematologic malignancies. They're the ones who basically are the trailblazer into this, and perhaps it's kind of fitting that we kind of close this session on precision medicine with
There's a
hematology.
fabulous book called The Philadelphia Chromosome, which tells the story of how, you know, the Philadelphia chromosome in CML was discovered, and then later on, right up to how clever scientists worked out how best to treat this disease once you understand the molecular basis of CML. So it's a marvelous book. If you can get hold of it, it's worth a read if you have a cancer patient or cancer doctor even. I've read it, it's fantastic. Yeah.
Lovely, Doctor. That hopefully, ladies and gentlemen, will make wonderful reading. Kind of look it up, and I mean, of course, there's much more things that you can do besides Netflix. Sometimes you just fall into a lot of watching, rather than reading. And as we draw the session to a close, Doctor, could I kind of ask you to leave our audience with some insights, maybe some notes or two that they can take home?
Don't be afraid of bone marrows. Number one, take home message. Done properly, it's very safe. It's a relatively painless procedure. And, you know, in fact, when we give patients the sedative, they don't remember very much about the event, you know. You know, don't delay when it comes to your symptoms, because I think what we are still seeing is people running around with disease which, you know, progresses unnecessarily. So early detection, early diagnosis often leads to a better outcome. And I think it's both education of patients as well as primary care doctors. So I think I'll be speaking on the lymphomas, what GPs should know at the coming MMA scientific meeting in May. I think I hope to touch on some of these for the primary care practitioner. Yeah. I think there's the drugs and the technology are improving by leaps and bounds. As I like to echo what Dr. Matin Mellor said, it's changed so much in the last 20, 30 years, where treatment is rather crude to very precise and targeted treatment. It's a challenge. It's a challenge to tailor what is best for individual patients. It's a challenge actually for us as hematologists too, because we have to juggle a lot of things. What is best versus the cost, and getting the best benefit for the individual. But I think if in doubt, always also seek a second opinion. Do not hesitate. I think sometimes it's worthwhile checking, but don't seek too many opinions and wait only until you see somebody who says what you want to hear. That's probably that's probably too late already.
That's of course the other kind of challenge as well, when you stop shopping.
Yes.
Right. On those very helpful insights, we'd like to thank Dr. Alan Tay. Thank you so much, Doctor, for joining us this evening. Dr. Alan Tay was a consultant.
My pleasure. Yeah, my pleasure. Yeah, really. Yeah.
Dr. Alan Tay is a consultant hematologist at Subang Jaya Medical Center. Ladies and gentlemen, this evening we've been very privileged. We've had three very interesting, experienced giants in their field really to speak to us. We had Dr. Matin Mellor open the segment earlier, and he's a consultant oncologist at Subang Jaya Medical Center. He was followed by Professor Pathmanathan, who's a consultant pathologist at Subang Jaya Medical Center, and now finally Dr. Alan Tay, who's a consultant hematologist at Subang Jaya Medical Center. And as we bring this segment to a close, I'd also like to thank not only Subang Jaya Medical Center, our partner for this session of Cancer and I, but also especially our partner throughout the entire series, Roche, Pharma, Shared Services and Diagnostics, for their invaluable support in putting this entire series together. And so we bring Cancer and I to a close for World Cancer Day. We've had 10 sessions, more than about 30 consultants come on, different, a whole range of specialities. We've basically put a National Geographic kind of series out for you, ladies and gentlemen. And this is on our website at cancer.org.my. You can go and re-look at every single session. For example, Dr. Allen's invaluable sharing this evening, one of the first ever hematologic malignancies kind of sharings we've had over Cancer and I for this period. And similar to Dr. Allen's session, we have many other very interesting sessions which are there archived for your benefit. So please feel free to go ahead and go back and browse back and listen and take all that you can out of these sessions. So we would draw, I think this brings really to an end NCSM's World Cancer Day this year. And we'll see you with Cancer and I as we resume next month on our monthly nightly sessions as we go back and look at different cancers. Thank you very much, very, very much for all your support, ladies and gentlemen, and we will see you soon. Good night.